Good.
Good? Okay, whatever. What test do you guys have tomorrow? Pulmonary. That's easy. Yeah. So what test do you have on Monday? That's right. Important subject of law. So, yeah, I said it. It's on recording. So, are we still good for test review tomorrow at lunch? Yeah, okay. So test review tomorrow at lunch, again, optional, not mandatory, but highly encouraged because, of course, you guys want to know what the answers are, right? Yeah. Well, yeah. Isaac's very, very blunt. So he's just north and south, big old smile on his face. All right, we're going to get started because we got some stuff to run through today. So, a couple of quick announcements. So today, obviously, is like Ortho Day, right? You guys have it this morning for 2 hours, and you have it this afternoon for 4 hours. So, do I think that this afternoon is going to take 4 hours? No. But, again, this is the last period of instruction we have for lab before the test, right? So it's time to get it in. So I will tell you this. We plan on hopefully being at the 2.5 hour mark, right, as far as accomplishing our objectives. May get done a little bit quicker. But I will be available the entire period for anybody who has questions. One-on-one, if you want to review some physical exams one-on-one. So make use of that, okay? Colonel Sylvester would be there as well. As you guys know, he's also an ortho PA, orthopedic surgery PA, more importantly. So the best in the world, right, that specialty. So, and then there'll be somebody named Major Villa, and then we'll have Colonel Rogers with us too. So we have a lot of subject matter experts. So again, utilize your time, ask questions, clarify things if you need to, and then hopefully by tomorrow, you're just getting the fine tuning on whatever subject it is you guys have questions about. Good to go? Any questions about the plan? Okay, we got that out of the way. Okay. So, we're going to start it today. So as you notice here on the slide, it says pediatric conditions, right? So I told you guys last time, make a mental shift when it comes to this part of the slide deck. And just understand that when you're talking about these conditions, they're primarily pediatrics. Okay, so again, when you're reading these scenarios and you're reading PANCE questions, ask yourself, is that painful hip in a child or is it in an adult? Because the presentations and therefore the pathologies are different. Make sense? Does everybody have hip pain? Yes. What makes it different is whatever the factors are as far as age, any history of trauma, etc. We've been going over that over and over and over, so hopefully you guys are keying in on that. Okay, so this is your topic list. Genovalgum, genovarum. Again, that's, some people say knock knees versus bow-legged. Okay, we don't really use those terms in orthopedics. We'll talk about in-toeing, out-toeing, leg calf herpes disease, also called LCP. Okay, that's definitely something sticky. Osgood-Schlatter disease, we already kind of went there. But again, why is this under pediatrics? Because pediatric patients have OSD, not adults. Adults have a history of OSD, right? The answer is yes. Okay. Slip capital femoral epiphysis, also called SCFE, right? SCFE. And then transient synovitis of the hip, which is not to be confused with osteonecrosis of the hip, which is in adults, correct? Okay, good. Genovalgum. So when we talk about genovalgum, then we talk about knock knees, okay? So again, when we're talking about genovalgum and varus, we're not talking about like just the fact that it's present. This is a developmental issue in pediatrics. As kids are growing, right, ages and stages, they're exhibiting these malalignments. You guys understand what I mean about malalignment, correct? So the tibia is laterally angulated relative to the femur. So anytime we talk about displacement or angulation, again, the principle that we need to remember is that it's the distal fragment in relation to the proximal fragment. So that's what that sentence means, okay? Did you go? If you understand that concept, you'll be good next block when you start talking about fracture displacement, okay? So get into that. Normal progression, am I going to make you memorize all the ages and stages for normal progression as far as degrees of angulation? No. Why? Because you're going to get more into that next block, but also because I don't remember them, if I'm being quite honest with you, for the most part, specifically because I looked them up, okay? And that's why those growth charts exist. Make sense? But what I do know is the normal ranges. And so I will expect you to know normal, okay? I think that's fair. No comment? Okay, perfect. So what's normal? 5 to 7 is kind of where most people sit, but upwards of 10 degrees can be acceptable, okay? So when you see somebody that presents, usually it's a pediatric patient that's brought in by a parent or a grandparent, as the book says, and they have concerns about the way it looks, okay? Looking at this picture, bless you, COVID. So looking at this picture here, if you look here, does one leg appear to be generally aligned normal, and then the other one just looks kind of malaligned, if you will?
Yes.
Yes. Okay, do you think that's more concerning? Well, in a few slides, I don't want to spoil it for Megan here. She gets excited. So, but yeah, that's not normal. Okay, so again, when you look at a presentation like that, we'll talk about it here in a second, but that's not normal. Okay, so again, they rarely actually have gait disturbance. Okay, so it's not that they're like having issues ambulating, it's just the way it looks. That's usually what parents or grandparents will say. Okay, they tend to be actually asymptomatic. But does it affect their ability to do like certain activities? Yes, and we'll talk about that. But for the most part, they don't have gait disturbance. So by gait disturbance, it means they're able to walk up and down the hallway, school, things like that, and they're not actually having any issues. Make sense? Okay. But when we know physical exam, I want you guys to key in on this stuff at the bottom here, okay? The difference between intermalleolar distance and intercondylar distance. When you guys are studying, key in on that. When we talk about this one specifically, so specifically genovalgum, we talk about the intermalleolar distance. Okay, so the knees are together, but the ankles, if you will, the malleoli are spaced apart. Everybody kind of see that from that picture there? Okay, not to skip on the slide, but that's the big thing you need to know here. Okay, intermalleolar distance. There's the concern, again, when we talk about ages and stages, is that when the height is less than the 5th percentile. I know that doesn't necessarily make sense to some of you, but when you get into pediatrics and you start talking about those growth charts, it'll make more sense. Okay, I would kind of key in on what I highlight on these two topics, okay, because that's what I think you need to know for now at least. So tibiofibular angle, that's measured with a goniometer. A goniometer is this thing right here. Okay, you'll see those in the ortho clinic. You'll see those in physical therapy clinics. And that's how we put it on the joint, and we measure the difference in the angulation between the tibia in relation to the femur, correct? That's the way we think about it, okay? So that's your tibiofemoral angle. Again, written for a purpose. It's not femoral tibial angle, it's tibiofemoral, because it's the tibia in relation to the femur. Good to go? Okay, any questions about that? Okay, good. So key in on this picture here, guys, okay? Increased intermalleolar distance. Okay, I highlighted there. I blew it up. No way. Okay. All right, so when we talk about what? Diagnostics, really what we do is x-rays, okay? And when we're getting x-rays, we're checking for that alignment, correct? So what we get is a weight-bearing series from the hips to the ankles. And you guys can see on the right-hand side there, that x-ray that I'm talking about. A lot of times if you look at literature, it's zoomed in. Okay, it's at the tibia and the femur, so kind of around the knee joint. But we actually look at the entire alignment to see what the issue is, okay? And you're going to get those, for most patients you're going to get them anyways, right, because that's the rule. But you're definitely going to get them if unilateral valgus is present, and that was that picture we looked at earlier, where one side appeared to be angulated, and the other one appeared to be normal. So that's a definite got to get x-rays, especially if you're going to refer to someone like me. And so if you measure yourself, you slap the goniometer on there, and the valgus is greater than 15 to 20 degrees, you're going to get it. Short stature, didn't we talk about that 5th percentile for height? That's where that comes from. Okay, good to go. So the only thing really different here is the angulation that concerns you that this may be a developmental issue. Okay, so the relationship between the x-rays and the actual clinical presentation. But so you see that, and you say, wow, that looks pretty significant, right? Then you look at the x-rays on the right, it doesn't look too bad. So really, again, you're talking about a matter of degrees as far as what you're going to do about this, okay? So don't get too freaked out initially as a provider and be like, oh my goodness, I got genovalgum, right? Just get the x-rays, figure out what angulation you have, move forward. Okay, treatment-wise, Usually, most kids, we say, let's watch it, okay? Let's take a look at it, just see how you develop. We'll continue to see you back periodically and just observe. So reassurance, education, and observation is kind of the rule for most patients. Otherwise, normal 3 to 4 year olds, definitely, right? They're still young, they still have a lot of room to grow, they still have a lot of room to correct any malalignment, and especially if they're asymptomatic. Again, you're going to ask patients that, and they're going to say, I'm just concerned about the way it looks, but nah, they don't really complain about pain. Makes sense? Kind of key in tying back into what we talked about. So operative really is only reserved for excessive deformity and or symptomatic, okay? So that's kind of the rule, all right? Can we make people different? Yes. We can make any patient different, but we want to make patients better. So that's the rule for orthopedics, okay? Growth modulation, I'm not going to get too much into that. That's, I could spend weeks on that, educating you guys on that. Come to fellowship, we'll get into it. But that's what you guys may know it as guided growth. So you basically put plates and try to affect the way that the tibia continues to grow, if you will, and affect that angulation, okay? And then realignment osteotomies, we've already talked about that. You basically make bone cuts and realign the bony alignment itself. This picture down here, do you have to memorize that picture? No, you can if you want, but it's just what we look at as far as angulation. So again, when I told you guys before, when you look at an x-ray, trust me, I'm looking at way more stuff in my head than you are at this point, because there's a lot more than just looking at it and saying, is there a fracture? Okay, makes sense? But it kind of gives you an insight into what we do in orthopedics. But you don't necessarily need to know that. In fact, I wouldn't spend much time on that, okay? All right, so referral decisions, red flags, kind of goes into what we were talking about before. Asymmetric, especially, right? So one side has genovalgum and the other side appears normal. That's always a referral, okay? Excessive valgum, so what was the numbers? 15 to 20, okay, good. Short stature, when we talk about short stature, again, don't spend too much time on this, but it's by definition, it's more than 2 standard deviations from normal from their age. That's based on those growth charts again, okay? And obvious genovalgum after what? 11 years old. You guys saw that previous slide, 11 was the key number, right? Once you get to 11, then, not on the guitar, on the amp, right? But you start saying, okay, there's not much more growth left. There's not much more room for correction of alignment, so therefore we might have to do something. So if you get an 11-year-old, or especially a 12, 13, 14, it's too late. They're not going to grow out of it. Make sense? So then you would refer those patients and let them know that we'll see them. Are you going to tell them that they're going to be pain-free? No. I will find you. Okay? Any questions about genovalgum? Okay, you guys get a sense of what you should study, right? All right, try to break it down for you guys. So now we talk about genovarum. So is that the bow-legged? Yes, that's the bow-legged, okay? So again, this is unilateral, correct? Looks like there's a little bit on the right side as well, but definitely more significant on the left, okay? The tibia, again, in discussing, it's medially angulated in relation to the, bless you, femur, okay? So what did I highlight there as far as normal ranges? That's what I want you to know. There's that term, 11 years old again, because why does it say adult? They're 11, they're not adults. When we talk about bone, we talk about open growth plates, right? So we use the term skeletally mature. So at 11 years old, on average, we consider pediatric patients to be skeletally mature. That means the growth plates are not going to allow for much more correction of angulation. That's where that comes from, okay? So this is easy to remember, right? 5 to 7 degrees, normal range is 0 to 10. Okay, any questions about that? Do you guys understand? Have you guys heard the term skeletally mature yet? No? Okay, let me just take a second. So skeletally mature basically means that the growth plates are closed. Okay, you look at an x-ray and you say, okay, even though they're 11 or 12 years old, the growth plates are closed, therefore, when it comes to saying that the patient is going to grow out of certain things, they're not, right? So then it can guide our decision-making as far as surgical options based on whether or not they're skeletally mature or skeletally immature. So skeletally immature is open growth plates. Skeletally mature is closed growth plates. Are we good? Okay, that's where that term comes from. You will hear that in orthopedics. That's how we talk. 11-year-old skeletally mature, otherwise healthy male, and then et cetera, what follows. Good to go? So you'll hear that. So now you guys are ahead of the game. Pathologic conditions, the list is long, right? But what I think you need to know, Blount disease. Blount disease is something that for some reason Pants loves it. Okay, have you guys even covered Blount disease yet? No, because I only really talk about the relationship of Blount disease with orthopedics, MSK. But Blount disease is something that we'll talk about here in a second, okay? Any questions so far? Okay, clinical symptoms, again, parents, grandparents, they're concerned. It just looks funky. Okay, it doesn't look normal, right? But are kids usually symptomatic? No, right? But with a large variceformis, then they have activity-related pain in the medial compartment. So do you think this child here is having issues with running around with other kids, maybe on the playground? Probably, right? Just looks weird, okay? And the kid may kind of limp after a while because it's putting pressure on the medial compartment. So we have a rule in orthopedics: thou shalt not varus. Whenever we make bone cuts, we don't want to put patients into varus. So when you think to yourself, which one's worse, right? Someone's thinking that. Varus is worse. Okay? Because it puts pressure on the medial compartment. What's the most often compartment involved in OA? Medial compartment. So you're basically causing early onset osteoarthritis and other issues, okay? Obese children are at risk. I highlighted that, okay, because you guys are going to start focusing in on fat kids, okay? It's not a judgment, right? But I'll talk about a condition later that you definitely going to remember the fact that the kid is obese, okay? But they're at worse risk of developing genoverum and should be regularly examined. What does that term mean, regularly examined? In primary care setting, you'll see them back, right? Not too often. Did it have big changes in 2 weeks? No. You're talking about a few months, okay? There's no real guideline for that, but I usually tell patients to come in, honestly, every 4 to 6 months, okay? But your book doesn't really distinguish that. I'm just giving you a little tidbit, okay? Because you're not going to see major changes. You see back every 2 weeks, you're going to get to know their favorite color, right? You're going to get to know you're going to get a lot of drawings that they're going to bring in for you. And so if that's your goal, great, but you're not going to see anything clinically, okay? So physical exam-wise, again, keying right into it, this is the intercondylar distance. So the ankles are together, but the knees are apart, okay? And that goes with Verum, right? You guys already know what Verum and valgus is. So this, again, is just discussing in specifics of pediatrics, okay? So again, the rule is there's a concern when height is less than the 5th percentile, okay? Tibial-femoral angle, excuse me. We discussed that before, okay? Again, using that goniometer. But the intracondylar distance is, like I highlighted there, in genioverum, it's increased intracondylar distance. You guys see that on the bottom right there? I added that just to highlight that, okay? So I would know whether or not the ankles are touching or the knees are touching, right? I would know that terminology, guys. Okay? Good to go? Okay. Any questions so far? So here it is. Blount disease in orthopedics, we call it bilateral tibia varus, right? So both tibia are varus, okay? And you see, not only are they varus, do you see that change right there where the bone looks bowed? Okay? It just looks like it's crinkled, if you will. That's what a student told me. I don't think we use that term in orthopedics. We don't, okay? But there's more than just the angulation. It's actual bony deformity as well, okay? So are you going to get weight-bearing hip to ankle views? Yes. Yes, and this picture is zoomed in, okay? But again, if you zoom out, you'll see that it's from the hip to the ankle. Because how do you get your tibial-femoral angle? How do you check your alignment from the hip down to the ankle? You got to get the entire scan of the extremity, correct? The answer is yes. So less than 25th percentile for height, severe for a child's age, and they're asymmetrical potentially. Okay, so again, when we're talking about Blount disease, it's going to be very pronounced. Okay, and you're going to see that bilaterally. Questions? Nothing yet? Okay. So treatment-wise, There's an example there of what they see how they slap that plate on with those screws and try to affect. Okay, those blue kind of outline right there, that means that they probably made a cut in the bone. That's an osteotomy, correct? And again, that blue cut right there, and then there's the plate and screw. They're trying to affect the way that the bone continues to grow, okay, continues to mature. So physiological varus, meaning if it's just something that's just normal developmental, you're going to reassure the patient, okay? Again, education and reassurance, okay? What's that key number? 11, right? Unless Blount disease is present. Blount disease is 100% surgical, guys. Okay? So infantile Blount disease, in parentheses, in bold letters, I put tibia vera, so you guys understand that's the same freaking thing. Okay? Sorry. It's the same thing. Okay? Because I know that sometimes on PANCE questions, they get tricky. They try to say, you know, they're like, oh, let me throw that in there and see if they know what that is, right? That's just understand they're the same thing, okay? Bilateral, okay? Good to go? So usually requires referral for treatment, so know that. Good to go? Okay. So bracing, we've really gone away from bracing. You know, the far stump stuff, right? Trying to make you run faster when you get older. All that stuff. Bracing has its role, but again, we won't get too far into that, but it is controversial. And really, bracing is something you do when you're watching and you're waiting, okay? You're just putting braces on there and hoping to affect some of that physiological growth. Good to go? But it is controversial, so we don't get too much into it in this course, okay? So operative, what's the key number there? Again, especially if it's tibia vera, right, which is also called infantile Blount disease, which is also called bilateral tibia vera, same thing. You want to get them before 4 years old. 4 years old, okay? Good to go? Because that's when you're going to do those osteotomies. You're going to make what we call bone cuts, and you're going to put plates and screws on, like this picture shows here. Any questions? Okay. Referral decisions, red flags. Again, physiologic genoverum. That just means, do you guys know what physiologic genoverum is? No? Okay, so let me break it down. So physiologic means it's just part of normal growth, okay? As patients grow, they kind of fill out their body, and their alignment kind of adjusts for their body habitus. They can actually get a little bit of bowing, right? Bow-legged, okay? And they can grow out of it. So physiologic means essentially normal developmental. Make sense? So if you call it physiologic, that means that you think, that the patient's going to grow out of it. Good go? So that means you don't think you need a referral yet, correct? Okay. Yes, ma'am. Of course. What's that?
What is the criteria for determining that it's physiologic?
The growth charts. Yeah, so if you fall into the growth charts, and again, that's why it's kind of a disservice that you haven't had pediatrics yet, but if you fall, this is a really good question. Her question was, what is the criteria for determining it's physiologic? You follow the growth charts. You remember that long list that I said you don't have to know all that? That's how you determine it. As they're growing, when the patient's in your clinic, you're going to pull up their growth chart, you're going to map out their ages and stages, and you're going to say, okay, in this age range, they should be this degrees, and they'll probably grow out of that. Good to go? Did I answer your question, man? That's an excellent question. That's probably the best question so far. It's also the only one. So, but older than 5 years old or worsening, because you want to get to them before they're 4, right? So that makes sense. That's a duh statement. But I put it in yellow just in case. Okay. Apparently the Army likes yellow. So. All right, so do you think that's normal or abnormal? That's unilateral, correct? Okay, so that's bad. That's something you would refer immediately. They're not going to grow out of that. That is not physiologic. That is, there's something going on there. Okay, good to go? Any other questions? All right, that's genovalgum and genovarus. That is in relation to pediatrics. That's not just saying that they're angulated. That's also saying what are the considerations for watchful waiting, what we call, reassurance, right, observation, versus we should do something about this. Okay, in genoverum, I just specifically discussed Blount disease. Okay, so don't skip over that. In-toeing and out-toeing. I had a student ask me last semester, is in-toeing, is that pigeon feet? I didn't know. I had to look it up, because we don't talk like that. But yes, it's pigeon foot. Okay, you guys sit in the park, you remember. So you sit in the park and you're feeding the pigeons, right, and walking around, they're all like this, right? Am I on camera? No. All right, so, you know, that's where that comes from, I guess, but we don't really use those terms. It's in-toeing and out-toeing. Those are not misspelled, even though they look painful. It seems like they're misspelled, but that's how they're spelled. So in-toeing, again, there's angulation inwards, and out-toeing, there's angulation outwards. That makes sense, right? But there's more to it than that, because which one's more common? In-toeing, perfect. Someone's doing a really good job of reading so far. Good. So, but causes, they can be plentiful. This is why when it comes to these developmental things, you can't really get a full grasp of this until you've had block 4, because you have to understand that there's rotational forces of the tibia that can come into play, and there's also rotational forces or deformities of the femur that can come into play, okay? So not only is it the relationship of the angle, the tibial-fibular angle, but it's also the rotation of either the femur or the tibia that can come into play. Does that make sense? So if you have rotation of the femur, it can seem more pronounced than if you have rotation of the tibia, okay? So what I would key in on that for now, okay, just for now, is that for tibial rotation, so rotation of the tibia specifically is more common in toddlers, and femoral rotation is more common in 4-year-olds, okay? So that's what I would key in for now. So then the same principle applies to out-toeing, but it's external tibia or femoral rotation. Do I outline there what's normal, what's abnormal, which one's more common and less common? No, it's not outlined there because it's a little bit more complicated than that. Okay, does that make sense? So if you think that when a patient comes in that they have in-toeing, usually they're not going to be painful. Okay, again, it's the thing where the parent or the grandparent bring them in and say, this doesn't look right. But what you're going to ask them, right, is activity-related questions. I highlighted there for you. Is in-toeing the most common? Yes. So you're going to ask common questions like, hey, not symptomatic. The patient doesn't complain about it. Parents are concerned about it. But is the kid tripping? Okay? Tripping as in, when they're walking, right? Not crazy or anything like that. Right? So tripping. Are they tripping when they run? Okay? When they walk faster. Okay? And then out-toeing is inability to keep up. I'm not going to demonstrate it, but if you want to, at the break, go out there in the hallway and try to run down the hall with your toes out, okay? You see that you can't necessarily run as efficiently, correct? Okay, but tripping is in-toeing, so know that for sure, 100%. Okay? Look at those toes in that picture there. Oh my goodness. Some dirty toes. All right, so physical exam-wise, you're going to have to define the magnitude of both in-toeing or out-toeing, okay? Magnitude meaning what degrees it is, okay? That's easier said than done, correct? Because I talked to you about tibial rotation versus femoral rotation. There's a lot more that goes into that, okay? But the question for you're going to ask is, they're not going to be symptomatic, right? But do they have issues when they're either trying to walk or run fast and they're tripping, or when they're trying to keep up with other kids and they can't, right? They're slower. Okay? So this is where it comes into block 4. Okay, I have to broach it because again, the hip is related to the femur, is related to the tibia, is related to the ankle, is related to the foot. But there's a lot of things you have to take into account when you're assessing that magnitude. And those pictures down there, do I expect you to memorize those right now?
Hopefully not.
No. Well, you need to know them in block 4? Yes. Especially the one on the right. I would, if you're a study ahead person, try to get that kind of like, take a look at it. So it's not the first time looking at it next block, okay? Foot progression angle, there's a lot there again, but it's basically just a progression of the angle of the foot as it outlines in this bottom left picture here. And saying, okay, is the foot progressing the way it normally should, okay? Based on degrees of measurement, okay, or measured degrees, if you will. Femoral rotation, thigh-foot angle. So do you think that thigh-foot ankle requires full-length x-rays? Yeah, they do, right? So again, the principle still applies. I'm not going to ask you those rotations there. I'll say that for your block 4 test. Okay, someone's writing it down, so don't get too worried about that. And then again, discussing foot alignment. Okay, you guys already probably broached topics like metatarsus adductors, correct? Okay, in some way, shape, or form. Okay, some stuff. Okay. We get more into that in block 4. Okay. Treatment-wise, when it comes to in-towing and out-towing, let's slow down for a second and think about this. I already told you that if it's in-towing, it's asymptomatic, they're not tripping. Do you think we're going to do anything about it? We're going to watch it. We're going to watch it. We're going to look at our charts, and we're going to say, okay, based on the degree of regulation present now, I think we can do education and reassurance, okay? Why? Because most cases will improve or resolve spontaneously. Okay, this is not gene variant valgum varus that we're talking about. This is in-towing, out-towing, okay? But most cases will resolve spontaneously. So therefore, ma'am, do you think that's physiologic? Yes, it is physiologic, right? So we tied that in. So that was a really good question. Okay? Still the only question, but the best question. So operative, less than 1%. Less than 1%. So if you call me on the phone and you tell me you got somebody with in-tow and you want to send them to me, what do you think I'm going to tell you? And say, why don't you hold on to it for a minute? Okay? Why don't you just watch it? Watchful ways. Education and reassurance. Okay? But if you look at it and you say, I am an expert at measuring rotation of the femur, and I'm an expert at measuring rotation of the tibia, and there's severe torsional abnormalities, meaning torsion, right? Rotational, okay? Then maybe you have a compelling case for me to see it, okay? But that's the exception, not the rule. Because how many patients have surgery? 1%. 1%, okay? So what are your referral decisions? If they have asymmetric, that rule still applies, right? You look at them and say, well, one's pigeon-toed, and the other one's either normal alignment or maybe even a little out-toeing. That's not normal. That could be a sign of a different disease process, okay? Metabolic issues with kids can cause these kind of presentations. Wasn't that the Blount disease thing we talked about? Okay, not in relation to this, but again, that's a metabolic disorder, okay? All right, there you go. So not improving up to 4 to 6 years of age. So if you had been watching this kid, right, and you're saying, oh, they're just not improving. They haven't made any degrees of improvement. What does the term not improving mean? It means they have not improved. They've made no improvement. Okay, just to clarify. It doesn't mean that you're going to wait to see this huge jump. It should be progressive. Make sense? So if over a longer period of time, let's say a year, you're watching them and they have no improvement, then they're not improving. Okay? That was a question that was asked last semester too. Good question. Okay? Any questions about in-towing and or out-towing? No questions? Okay. LCP disease, okay, or LCP, excuse me. When we talk about this, it's leg-calf-Perthes disease, okay? Those are people, okay? Those are not like body parts, right? So it doesn't necessarily mean that that's what's involved here. Okay, just understand that. So when we talk about the definition, it's idiopathic osteonecrosis of the femoral head. So do you think that's a disruption of the blood flow for some reason? Yes. That may be unclear? Yes, right? LCP. Okay? But this is specifically in pediatric patients. So you don't use the term AVN of the femoral head, right? In kids, you would say LCP. Leg-calf-Perthes disease. Okay? Clear? Okay. So when you're reading the questions in a few days, okay, or when you're studying Sunday night, finally, you'll look at it and say, what makes it different? Well, this one's pediatric for kids. Okay? They're younger. Okay. Most commonly diagnosed in boys between 4 to 8 years old. 4 to 8 years old. So if you see a parent's question that says a 5-year-old male, then LCP is in your wheelhouse as far as your differential, correct? All right, so when we talk about LCP, does everybody kind of understand that collapse again that we talked about at length before with adults in this picture here? Mm-hmm. All right, there's a disruption of the blood flow that can lead to collapse of the femoral head. Do you think there can be a crescent sign present? Yeah, there can be, okay? But again, specifically this is for kids. Clinical symptoms can last up to 18 months, and radiographic healing, believe it or not, can take up to 5 years. Have you guys heard the term radiographically healed? No? Okay, let me break it down real quick. So radiographically healed, there is different than clinically healed. Radiographically healed, I get to come over here finally, it doesn't make that sound. All right, so radiographically healed means that you see it healed on x-ray completely. You see no evidence of whatever the pathology was, okay? Clinically healed means that they don't have any symptoms, like maybe tenderness of palpation, et cetera, okay? Or like a physical exam finding, okay? They're clinically healed, all right? Do you think for an MCL sprain that you're gonna get x-rays, like sealed x-rays on the soft tissue injury? Yeah. No, you're just gonna keep doing your exam, and you're gonna say, okay, initially the MCL felt loose, and now clinically it feels not loose. That's clinically healed, right? That makes sense? So when they talk about radiographically healed, in this case, it's because you're gonna see bony changes on the radiographs, and then you're gonna follow up. Sorry, don't get that. So, so you're gonna follow it out, but you're gonna follow it out a pretty long period of time, correct? You think you're gonna refer most of these patients?
Yes.
Yeah, and you will, okay? Pediatric orthopedics, okay? That's a specialty if you guys didn't know, so. But if the prognosis is worse in older children, due to what? We talked about this, that potential for remodeling, okay? That the fact that their growth plates are not open anymore. So those principles still apply, okay? Make sense? So I would know the radiographic healing, just the fact that it takes a longer period of time. Is it exactly 5 years? No. But it can take up to 5 years. So it's a prolonged period of time. Okay? Serial x-rays, multiple x-rays over time. Limping and limp is highlighted here. You think that's an important concept? Yes. It's going to be a 5-year-old boy. Sir.
So if I had a clinically healed patient that wants to do sports, do I discourage them until they're radiographically healed?
That's a good question. So his question was, if you have a clinically healed patient, should you discourage them from doing sports until they're radiographically healed? The answer is, in this case, yes. Okay, you open a can of worms. I like worms when I go fishing, but let's not go fishing here. Okay, I will answer it specifically for this condition. You're going to watch them until they're radiographically healed. Are you okay with that answer for now?
Yes.
Because then I'll chalk you up next block, and you'll be like, but he said, right? And then I won't be here. And then I'll be around. And then you'll be like, but he said, right? You'll get it wrong on the test. But in this case, to answer your question, you're going to follow them out until they're radiographically healed. Okay? Makes sense? The limp is going to go away pretty quick, hopefully, but the x-ray findings may not. How many years? Up to? 5. Okay, there you go. So does that mean they're not going to do any activity? No, but they're going to limit their activity. Okay, makes sense? So now's not the time to start taking on judo at the age of 5. Okay, all those 5-year-old judo artists, so practitioners. So symptoms, all right, so they have limping for 3 to 6 weeks by the time they present. So when they come into you, the parent will say, he's been like this for 3 to 6 weeks. Okay, good. And then you're going to also ask them, you guys know your OPQRST, right? The timing, the T, right? You're going to ask them more questions, and you're going to get to the point that their symptoms are worse at the end of the day. Okay? Do you think that it would hurt to be doing activity on a femur, a femoral head that has ongoing osteonecrosis? Yeah. They're progressing their pathology. Okay? And then when you do your discussion about where does it hurt, right? The patient usually will get this vague kind of pointing to their groin and or the proximal thigh. So the proximal thigh can be that bar question, right? The OPQRST. So it could be groin pain that radiates into the proximal thigh. Okay? Groin pain that radiates into the proximal thigh. Groin pain that radiates into the proximal thigh. Good. Okay. Good. All right, so everybody has this picture on the right memorized. Everybody knows the difference between Trendelenburg sign and Trendelenburg gait. Okay. Everybody knows in this class knows that Trendelenburg side is the drop of the pelvis when lifting the leg opposite to the weak gluteus medius. Okay. Everybody knows that. Well, we'll know that by Monday for 100, right? As my kids say. Okay? So with range of motion on physical exam, they're going to have restricted abduction and internal rotation. Okay? So why is that? Because that's the areas, as we talked about in FAI, they cause that pain, okay, on the femoral head as it articulates in the acetabular. Okay? Guarding extremes of motion, so you put them into hyper hip flexion or hyper hip extension, usually when they're sidelined, right, or on their belly. Okay, and if it persists for long enough, this is the enemy of orthopedics, right? Stiffness, they can get a flexion contracture. And not only do you have a bony issue, but now you have a soft tissue issue as well. Excuse me. Gait, it goes on to say abductor lurch, okay, and then it says trendelenburg gait. The reason I put waddling there is because, and no, I'm not going to demo it like the last semester students asked me to do. But basically, if you think of a waddle, everybody knows what a waddle is. I'm doing it right now, off camera. Okay, this is more of a waddle. And abductor lurch is what it sounds like. It's more of just the legs like this. Okay. Can I demonstrate it accurately? No. Okay. But I'm just telling you that I'm not going to ask you to differentiate trendelenburg gait from abductor lurch. Okay, lurch is more of a kind of a forward thing. Everybody knows what lurching forward is, right? So when they're walking, they're kind of doing this, and in waddle is more like this. Okay, everybody see that? No round of applause. But waddling is that trendelenburg gait. That's the one I do want you to kind of know. Okay, because that's something that you can say, okay, I understand that in trendelenburg gait, they have gluteus weakness, and therefore they have a positive trendelenburg sign, which will lead to a trendelenburg gait. Pause. Anybody? Questions on that? Okay. Moving on. Diagnostics, AP of frog leg. Okay, remember we talked way back, seems like forever ago, in our MSK radiology, the AP frog leg is pediatrics. Okay, so you're going to get those. These are pediatric patients. But as we discussed in osteonecrosis of the femoral head in adults, do you think you're going to see that collapse initially? No. Okay? So the radiographs may be normal early on. Okay? So if you have a strong suspicion, you think, and they're limping, and they're 5 years old, for example, okay, and they're a boy, a male, right? Do you think you're going to protect them, protect your weight bearing? You are. Okay? And the findings can evolve over time. All right? So this is in relation to osteonecrosis of the adults, of the femoral head, excuse me, in adults. This can actually develop over time in kids. Okay, so maybe more of a prolonged course. So again, take a look at the symptomology as well, and the age, and it'll give you more of a hint that, hey, we're talking about LCP here. So that there's that subchondral fracture, that crescent sign. Can you guys see the crescent right there? Okay, that little crescent area there, right there. Okay, that's the crescent sign. That's an indication of subchondral fracture. Okay. Yes, sir.
Would this damage the growth plate?
It can. It can, absolutely, 100%. And we'll talk about it here in a little bit. So his question was, could this damage the growth plate and cause leg? I think you were talking about leg alignment issue. Yes, it can. That collapse will cause the leg of the affected side to be short, correct? Makes sense? Okay. That was a good question. I don't know if it was a better question or just a good question. So fragmentation stage, so that makes sense, right? It's collapsing, it's fragmenting. Okay, that's the early stuff. So that epiphysis is collapsing. Everybody knows what the epiphysis is, right? Compared to the diaphysis, compared to the metaphysis. If you don't, I'm gonna get there. You're definitely gonna know it next part. And then reossification stage is healing. What is ossification? It's making bone, right? So it's reossifying, it's remodeling, it's healing essentially. Okay, so that's the healing stage. Good to go? Did I just put a chart up there that asks you what stage is this? Tell me. No, it didn't. I didn't do it on purpose because kids are more challenging. Okay, in general, but also in this condition. Okay, MRI used mainly for staging. Okay, and prognosis. Do you think it's better to catch this early?
Yes.
Yes. 100%. Okay, so there it is. It's right there. You're excited today. I like it. So secondary OA, obviously, but likelihood discrepancy, it'll cause the shortening of the segment, correct? Okay, so there it is. So that's an adverse outcome of the disease itself. Treatment, I cleaned up this slide. Left-hand side, basically the goal is to maintain a spherical femoral head, okay? That will allow for normal development and no issues long-term, hopefully, okay? And with that femoral head, you want it to be congruent with the acetabulum. What that's discussing there, have you guys heard the term congruence in association with orthopedics, let's say? So congruence is when you say the joint, the relationship between the proximal and the distal segment is congruent, meaning in this case, is the hip joint a ball and socket joint? Yeah, it is. So it's saying that the ball and the socket are in a healthy relationship. That's what it means by congruence, okay? So next block, when you guys start talking about incongruency of joints, specifically fingers, maybe toes, things like that, more toes, right? You're talking about congruence of that phalange with the more distal phalange. Okay, that's an example. Okay. Any questions about congruence? Okay. OSD, Osgood-Schlatter disease. We already kind of covered this, but again, OSD is something used specifically in pediatrics. And defining, I cleaned up this slide as well. When you're talking about Osgood-Schlatter disease, you're talking about repetitive stress on secondary growth centers. Okay, so what that can cause is reciprocal changes on X-rays. Okay, so tibial tubercle. When you talk about the tibial tubercle, it's going to be OSD. When you talk about the distal patella, it's going to be something called SLJ. So this is new topic. Okay, so new information here. Sinding Larson. Okay, Johansson. Okay, so make sure when you're reading the questions, guys, that you're reading the question for where the abnormality is. Because if it's tibiotubercle, it's always going to be OSD. If it's the distal fold of patella, it's going to be SLJ. Treatment's basically the same, but maybe understanding what the relationship is on radiographs or anatomical landmarks is important. Okay. So what's your typical patient? 11 to 13 years old, active in sports, five times active, right? So 5 times more propensity to be present if they're active in sports. Okay. Boys, 2 to 3 times greater than girls. Okay. So they're 2 to 3 times more likely, okay, to have OSD. Make sense? Okay. I have seen OSD. No, I have seen a history of OSD in adults that were females, but I can tell you that there was a greater number of males that had that. Okay, I will tell you that that's true, very true. Okay, so clinical symptoms-wise, they're going to have pain exacerbated by quad activities. That's an extensor mechanism stuff we talked about before, correct? Yes. Okay, that's what it is. Right, the quad activation. Okay, so running, jumping, kneeling. Theater sign, there it is. Is theater sign specific for anything? Have you learned that it's not? You have, right? So it's specific for nothing. But theater sign means when they're seated and they're putting a stretch on that extensor mechanism, they have pain. Okay? It's not pain with activity necessarily. Would you give that definition? Okay. So where do they have tenderness to palpation? If it says a tibiotubercle, it's OS. That's how we typically abbreviate it. Osgood-Schlatter. It can be OSD as well. Okay. If they have pain of the distal fold patella, then it's going to be SLJ. Okay. Usually, when they have some form of OS or OSD, Osgood-Schlatter, they're going to have a palpable mass at the tibial tubercle. So if you see a question that says palpable mass at the tibial tubercle, you're excluding SLJ, correct? The answer is yes. And then you're going to assess gait and alignment. Okay. How do you assess gait and alignment? Have them walk and watch them walk. Right. So if I'm pretending like the patient's walking down the hall, I'm standing here, patient's walking away from me, and I'm kind of watching them. Okay. Is there any gene of varus of albumin present, et cetera, et cetera? That's what we're talking about with alignment. Okay. So remainder of the exam is typically normal. So they have very focal, very pinpointed symptoms. Okay. Radiographs. Okay, you see that the difference there. The circle is SLJ, correct? This is distal patella. See how it's stretched out there? Okay, and then the bottom arrow there can be, it is OS. Okay, so can you have elongation of the patella also with OS? You can. Okay, not to confuse you guys, but just so you understand, you still want to do a clinical exam and see whether they're tender. In this case, do you think it's more OS because they have that distal, they have that tibiotubercle abnormality? Yes. Okay, did I confuse anybody? Not yes? Okay. So why do they have that pulling? Why do they have that ability to pull and not rupture? It's because they have an unfused apophysis. So the growth plate, correct? So they're able to continue to have stretch because it's not closed. So are these patients skeletally immature? Yes. Okay. Good. Hopefully we'll put it all together. Treatment-wise, again, very conservative stuff. Severe recalcitrant, meaning if they're actually having limping because of this, we may put them into a knee immobilizer. We talked about that before. Why? Because it doesn't allow them to bend the knee, correct? So it gives them relative soft tissue rest, keeps the extensor mechanism from getting stressed, essentially. Okay, but that's the only case. We very rarely would use an immobilizer in kids. Okay, but what we do is, what I highlighted there, we modify their activity. How long? 2 to 3 months. Now, if the kids are super active, do you think they're going to complain about that?
Yeah.
Yes, but you're going to educate the parents on how important it is, because if they keep coming back every 2 weeks and saying they still have issues, and you document they're non-compliant with treatment, then that is their issue. Okay? Operative, rare. Like super rare. Never seen it. Never done it. Never been involved with it. It's just not something. Okay? Do you want to affect growth plates in kids? No, you want them to continue to grow normal. Okay? So basically what you do is you go in and you take out those areas of HO, that heterotopic ossification that we discussed. Okay? So what is this red flag here? Can kids get patellar ruptures and quad tendon ruptures? Yes, especially partials usually, partial tears, but can they get ruptures? Yes, they can. So if you find this finding, that is an absolute referral. That's what this is getting at. Okay? Let's take a break. You guys is 0800. Alright, I've been getting you guys, all cleaned up after other people have had their ability. Alright, so I don't know how much how I feel about that, but I appreciate your attention this morning. We're kind of flying through stuff, but I'm going to be good on my review tomorrow. Okay, and again, I keep telling you guys, make sure you're asking questions at the lab today. Okay, I'll wait till tomorrow to start, tomorrow afternoon to start kind of looking at stuff and say, oh shoot, I didn't really understand that. Okay, it's okay if you have questions. I'm not saying don't have questions, but you need clarifying. The rule applies this time around as well. If you guys text me, will I respond? Who in here has texted me before test questions? Or test questions? With clarifying questions. Yeah. Nobody wants to test us? Okay. So people have, okay? So do I respond? The answer is yes. Okay? Now if you text me at 2 in the morning, I will not respond until 4:30, 5 o'clock. Because I like to get some sleep. I don't sleep very much. So but that's just the nature of what I do in my other life. So, any questions about any topics we discussed so far? No? Okay. So, I thought that was a natural place to break. Now we're going to talk about Skippy. So, slipped capital femoral epiphysis. What is the capital? The dome. Right? Everybody agrees that the capital has a dome? Okay. So, do you think we're talking about the femoral head? Okay, capital femoral epiphysis. So that's the epiphysis. That's the proximal segment, proximal portion of the bone itself. Okay, so again, we're talking about pediatric stuff. So proximal capital towards the head. Femoral epiphysis displaces from the femoral neck. Femoral head displaces from the femoral neck. Okay, so if you think about the femoral, the head of the femur, as the top of an ice cream cone, then you'll progress on to the next discussion that we're about to get into. I know you guys have gotten into Skippy a little bit in other courses, right? A little bit? Yeah. So typically occurs during adolescent growth spurts. Is the cause known? No, not necessarily. So it can be idiopathic, correct? So shear forces, so we talked about what a shear force is, right? Shearing, okay? Shearing forces, okay? So it's a slippage, all right? But that's more of a medial to lateral or lateral to medial slippage, okay? So we're talking about shearing in terms of orthopedics, okay? So Salter-Harris 1 proximal femur fractures. You guys remember Salter-Harris classifications, right? Of course you do. Don't worry. Colonel Sylvester will make sure you remember it next block, okay? But you do understand that that is an insult to the epiphysis, correct? Okay. In this case, though, I like how he's always laughing over there. Yeah. And in this case, though, it's not just something you may not be able to discern. You can actually see it. The ice cream cone is falling off. Okay. The ice cream is falling off the cone. Excuse me. It's falling off. Okay. So here you go. I highlighted this word, and you will never forget it now. You're looking for fat boys. Okay? Fat boys with a limp. Okay? Not the group from Miami. Okay? Fat boys with a limp. Okay? So what's the age range here?
13 to 15.
13 to 15. Do I agree with the designation of black, African American, etc.? No, I don't necessarily agree with that, but I guess that's what the studies say, and that's what your book highlights. I'll say fat, white kids, fat kids, but specifically boys, okay? Boys, boys, boys. What's that age range again?
13 to 15.
13 to 15. All right, do girls get it younger?
Yes.
But is it more common in boys?
Yes.
Okay, and can it be bilateral?
Yes.
Up to half the cases are bilateral, so make sure you're assessing that, okay? Good to go? But these kids will have a limp, right? Yes. She gave me that look. All right, so you see the ice cream is on the cone there, right? And here, it looks like it's slipped, right? So that's when we talk about that slippage, that shear, okay? So if it progresses, do you think they're going to have leg length discrepancies?
Yes.
Yes. Okay, the ice cream falls off its cone. I added that. Okay, because I want you guys to remember it that way. Okay? I know you guys have had it somewhat, but here's your picture. If you burn a picture into your brain, this is what you're talking about with skipping. Okay? Right? What age is this kid? 13 to 15. Okay. So adolescence. Okay. Displacement of the femoral head to disruption of the growth plate. So the ice cream is falling off its cone. Okay. And can they have referred pain to the thigh or the knee?
Yes.
Yes. I already covered that concept before, right? That thigh pain can be knee pain can be thigh pain, buttock pain, etc. Okay. So treatment is percutaneous screw fixation. What does percutaneous screw fixation mean? You see this picture here? You think we make a big gaping incision to fire that into the femoral head?
Yes.
No. Percutaneous. Yeah, the answer is no. Okay? So percutaneous just means that we can make a little stab incision, a little nick, if you will. So you guys know where the different blades are, right? A 15 blade, 10 blade. No, of course not. Right? Why would you? You're in K school and you haven't had surgery yet. But you would understand that there are some scalpels that are serrated on both sides, not just one side. Right? So we can take that specific type of scalpel and poke. And it goes right in. Right? So think of it like a knife, a double-edged knife. Okay? That's that concept. Good to go? Okay? So percutaneous screw fixation. Do you think we'll do that for most cases of skipping? Yes. So know that. Okay? Limp is common. All this other stuff, yep, read the scenario, get to it. But what you're looking at is you're trying to discern if they have a limp. If it says they have a limp, and as we were discussing on break with someone else, then make sure that you don't just focus in on limp and say what? LCP, right? Take a look at the demographics, take a look at the presenting factors, and decide what is more common, right? Usually on pants, they'll give you some kind of radiographic finding. Okay, so know those radiographic findings. Okay, so when we're talking about skipping specifically, you're going to have the ice cream falling off its cone. When you're talking about the other condition, LCP, you're going to have collapsing, correct? So that terminology is important, okay? And it'll develop gradually, okay? Externally rotated limb, you remember way back, right? Seems like forever ago in block 1, when I told you guys that if it hurts to walk, to do internal rotation, that they'll actually walk in external rotation to relieve that pain? Yes, right? So is that a gait disturbance? Yeah, that's a gait disturbance. And that's what that's getting at. What's the most sensitive and specific finding? Loss of hip internal rotation, right? Okay. If the ice cream is falling off its cone, do you think you're going to have concentric motion of the femoral head with the acetabulum? No. So we're tying concepts together. Okay? Makes sense? And again, the effective limb is shortened. Okay? So if you look at that test there, all that test is really showing you is that you're flexing the knee, you're flexing the hip, you're bringing it proximally, and then you're internally rotating, bless you, the hip, right? But the foot goes externally. We understand that concept already? Okay, I hope you do. I mentioned that before. Make sure you understand how to describe this. Okay.
So would that be
Yes.
loss of active hip internal rotation or passive?
Usually with this one, that's a good question. So his question is, do they have loss of active or passive? Well, if they have pain, let's think about this real quick. That's a good question. So, not the worst. But if you think about it, if you tell them to flex and internally rotate their hip themselves, you think they're going to want to do it?
No.
Oh, it hurts, right? So this is a passive thing. That's what I'm talking about here. I will add a parentheses there and put passive for the future generations. The guys that you're going to be preceptors for. Woo! Scary stuff, right? Yes, someday. So radiographs, okay, again, are you going to get an AP and a frog leg view?
Yep.
Yes, because it's a pediatric patient, correct? Okay. And then when we talk about the Klein line, we really only talk about the Klein line for purposes of my course in relation to skipping. That's the capital femoral epiphysis. So that's a line that's drawn. Can you guys make this out here? It's a line that's drawn the lateral neck of the femur through the head of the femur for the epiphysis, and it should bisect what? It should intersect, the lateral capital femoral epiphysis, so the lateral aspect of the capital femoral epiphysis. That is it, the ice cream that's on its cone, correct? So do you think an abnormal finding then is when you draw that Klein line and it doesn't intersect with the lateral capital femoral epiphysis, or the dome, if you will? That's it. That's what it is. So this is a picture here that's meant to show you this is normal here, right? And this is normal here, right? Because it intersects with that lateral capital femoral epiphysis. And then when you draw the line on the affected side here, right? And the affected side here, it doesn't intersect. That's your Klein line. That's an abnormality with your Klein line. Am I going to ask you to draw Klein lines? Who said yes? 51 questions. All right, no, the answer is no. But I just want you to understand that concept, because what's important for you guys to understand is, do you think radiologists speak like radiologists?
Yes.
Yes. So they may not tell you that they have a concern for skipping. They may be fancy because they get paid by the word, I swear. And they may say there's an abnormal Klein line, and the measurement is, and here's your measurements here, and here. And I think you need to know all that?
No.
Not necessarily, but what's in yellow? Okay. Severe, I want you to know. So 50 and less is what? Not severe. But if you get a patient that presents with 50, that's severe. So again, you read that report. Radiologist wrote 3 paragraphs that really only took 6 words to describe, right? But then you see that measurement, you're like, it's greater than 50. That's severe. That's something you need to address immediately. Okay? And usually, again, that's what? Surgical. That percutaneous. Is he trying to escape? That percutaneous pinning that we talked about, correct? All right? So why would we get an MRI? If the radiographs are inconclusive, you still have a question. Do you guys get the sense that we use radiographs a lot for bony abnormalities to kind of like get a sense if there's something underlying that we're missing? Do you think we're doing that a lot? We are. Okay. So not routine because we treat most conservatively. Okay? And that, again, it can be conservative, especially on the lower end of the spectrum. So if it's mild, so not less than 30, that's definitely going to be something where you just tell them, hey, treat it this way versus if it's greater than 50. Make sense? Did I do a good enough job explaining those degrees to you guys? And the Klein line? Okay. Understand Klein line measurements. If you see that, I won't necessarily give you a Klein line measurement that's positive if it's not skippy. Okay? I wouldn't. Would pants do it? I don't know. I'm just telling you, they'll tell you that the kid has severe limp. They'll say words like severe. Okay? Do we speak like that in orthopedics? No. Okay, but I'm just, we actually say the angulation is 46 degrees, and we all know what that means. All right, we don't use words like severe, significant. It's not, when you do with that word, it doesn't mean anything, right? One is the degrees, that's what's important, okay? Good to go? All right, so treatment again, absolute non-weight bearing. Not only is it in yellow, but it's underlined. So why do I tell you that? Because if you're suspecting a patient as skippy, it's a fat kid, about 13 to 15 years old, okay, I'll never forget it. Do you want to tell them to get off it? Yes, and it's absolute. You guys, in relation to science and specifically medicine, you understand the difference between absolute and relative, correct? Relative is patient factors, absolute is 100% you do this. So 100% of the time, non-weight bearing, okay? Do you think the ice cream will fall off its cone more if they continue to be weight bearing?
Yes.
Yes. Do you want to keep it from getting to 50 degrees?
Yes.
Yes. You want to keep it from getting to 30 degrees, okay? So definitely 50, okay? But that's the principle at play here. You want to stabilize the physis, okay? Again, no growth abnormalities. Can you get osteonecrosis secondary to skipping? Yes, but I won't get that tricky on your test questions, I promise. Okay? That's not because I don't think you need to know that. It's just because I need to make sure you understand that when you get certain factors, it is this, and it's not that. Good to go? And then overall goal is to maximize function. Okay? Do you think that in orthopedics we're function over form? Yes. We oftentimes take things and make them crooked to make them straight. That concept doesn't make sense, right? But we do it. And we make things a little crooked to in the long term make them straight. You'll get into more of that in fracture management. Okay? All right. Crooked casts make straight bones. You'll hear that next block. Okay? So screw fixation, bless you. A lot of code in this room. So screw fixation, you can use 1 or 2 screws. Don't worry about that. Okay, I'm joking. 1 or 2 screws. Okay, let's not get into that debate. Okay, but do you think you fire that screw wherever the head is? Yes. That's why you want to hopefully fire a screw into a head that's not greater than 50 degrees, because then you fixate it into a position that potentially could be long-term detrimental to normal function. Make sense? But what we don't do, just to be clear, I won't ask you this, but just to be clear, we don't slide the cone. Okay? We fire wherever it's sitting, unless it's displaced, it's somewhere out in space, then we have to put it back where it's sort of supposed to go. But we don't try to make it perfect. Can you insult the growth plate to a greater degree the more you're futzing around with it?
Yes.
Yes. So again, we just usually fire in place. Hopefully we catch these early. That's what I'm trying to say. Okay? So what's in red? All patients immediately. All patients. Okay? So without almost exception, most patients should get a surgical evaluation. Does that mean that we're necessarily going to do surgery? No, but you need to send them. Okay? So, but until they're seen by us, right, you're going to make them absolutely non-weight bearing. How do you do that with pediatrics? Wheelchair, if you must. Do we hate wheelchairs in orthopedics? Yeah. Yep. Absolutely 100%. But if you must, right, you put them in a wheelchair until you can get them crutches, right? Let's talk about this real quick. This sounds intuitive, but now crutches, do they come in different sizes?
Yes.
Yeah. Do most places have adult over 5'9" and then over 6'5" crutches?
Yeah.
Most do, but do most places have pediatric crutches? No. Okay. So what, I've had to, even in the past, tell the parent, until you're seeing my orthopedics, you need to carry your child. Because we didn't even have a wheelchair. Okay? Make sense? So that's, if push comes to shove, that's what you do. You don't want that ice cream to fall off its cone. Okay? Carry your own child, not someone else's. Okay. I don't know why you laugh about it. Anyways, I know that sounds intuitive, but I've gotten that phone call before. It's like, we don't have any crutches, we don't have any wheelchairs. Like, can the parent lift the child? Yes? We're good here. Okay? Just use some common sense.
Laughing because of the demographic.
What's that?
We're laughing because of the demographic. It's 13-year-old and heavy.
Yeah. So the 13-year-old fat kids, you'll never forget it. But again, will they give you some degree of like maybe a loss in internal rotation on the exam and plus or minus a radiographic finding? Yes. So read the question, get to it. Don't just focus on lip. Go down, and just so happens LCP was the first choice. You circle that one and move on, but you didn't read the rest of the question and realize this is actually skippy. Make sense? Okay? Here you go. I know. You'll be fine. Just slow down and just look at it. Remember how I told you guys way in the beginning to lay these conditions over each other and see how they're different? That's how you do this. And you put them over on top of each other, and you see how they're different. Okay? What kids get LCP? What's the age? Are they adolescents?
Yep.
No, they tend to be younger, correct? 4 or 5. And they tend to be younger. Okay? Make sense? Is the world like that, guys? Does the world correspond to everything I teach you in the textbook?
No.
No. Well, for the purposes of testing, because I know that's all you care about, I will hold to what I'm teaching you. Okay? Because that's fair. Okay? I haven't talked about fairness in a while, but I try to be fair. Okay? I need to stop folding my arms like this now. All right, so transient synovitis of the hip. So again, we're talking about, if you're using the word transient synovitis of the hip, don't call me and tell me you have a 25-year-old male with transient synovitis of the hip. That's not a thing. This is only in pediatrics. Okay? We only use this terminology in transient synovitis of the hip in pediatrics. Okay? Transient. They're not homeless, right? It just means the condition, if given a long enough period of time, will go away. Do you think that means it'll go away on its own then? Yes. So it's in the word there. Is it synovitis? Yes. We know that the hip joint is a synovium, correct? So it's inflammation, but is it infection? No. This is non-septic arthritis of the hip. Can kids get septic arthritis of the hip?
Yes.
Yeah. So what do you think the most dangerous, I haven't even gone to the next slide yet. What do you think the most dangerous thing to miss is?
Septic arthritis.
Septic arthritis, and then you diagnose this as a transient synovitis of the hip. Okay? This is one of the last patients I saw before I had PCS here, and began the long journey. And the patient was there for about 4 hours, because as we're going to talk about here, it's a bit of a workup. Okay? And you're going to rely a lot on your physical exam. So this is a sterile inflammation of the joint. Sterile. Okay? Meaning it's not infectious, correct? Okay. How long does it take to resolve?
4 to 6 weeks.
So if you do nothing, that's what that says. Therapy or sequelae, right? You don't know what sequelae is, right? Secondary factors, secondary development of conditions, or factors, if you will. All right, so 4 to 6 weeks if you do nothing, a lot of times, okay? So do you think that some of these patients never see you?
Yes.
Never get seen in urgent care, never get seen in ER? Yeah, right? So, but if they do, it's a common source of limping in a 2 to 7-year-old child. 4 and 5 tends to be something that they like to stick to, but it tends to be younger. Okay, the kid I saw was 4 years old, and you're like, wait, didn't we just talk about 4 with something else? Yes. Again, lay them over on top of each other and see how they're different. Males are 2 to 3 times more common than females. Okay, males are 2 to 3 times more common than female. Etiology is unknown, so idiopathic, right? And can there be a history of trauma? Do kids fall a lot?
Yes.
Yeah. So that, I don't know how much faith I would put into that, because they'd say, well, he fell like 2 weeks ago, right? It's like, well, does he fall a lot? Well, he's a kid. So then you just get that kind of, parents get that confused look when you ask that question, right? So, but what is the rule here? for the most part, especially in a testing environment, is there is a history of a viral illness that precedes it days to weeks before the onset of the limp. Okay? So see how it says GI or GU? GI or URI? URI, right? Upper respiratory infection. So it said they were sick 2 or 3 weeks ago, and now all of a sudden they developed this limp. Okay, so look at the history when you're reading the scenarios on Monday. Okay, look at the history. Okay, because will they have a limp? Yes. So again, don't just see limp, see 4 years old and stop reading, and then circle an answer. Okay, good to go. Okay. Somebody's trying to duck in on my course. So decreased range of motion, particularly in abduction and internal rotation. I think you guys are getting a sense now that when you do abduction and internal rotation, right, that causes more of the femoral head neck to make contact with acetabulum, correct? So we keep talking about that. And then guarding at extremes of hip rotation. And again, going back to the abduction internal rotation, passive. Passive. Okay, if you tell a kid to do it, they won't do it, and they'll do it wrong, right? So you're going to be laying hands, essentially, okay? So when you're talking about guarding of extremes of hip rotation, okay, so that's when you take them and you go way out and you go way in, okay, and they have pain, right? Is that causing the synovium to become more angry? Yes, that's what you're doing. You're reproducing that, okay? So adductor lurch, cantilever gait, sure. Usually with these kids that have this, is this some kind of an abnormality of the femoral head?
No.
No, this is a synovium issue, correct? So they usually will do some kind of weird walk, but more commonly than not, they will actually not want to put weight bearing on it. Here's, if you've never heard this before, here it is for the first time. If you've heard this before, here it is for the millionth time. You will do not discharge a patient from your clinic, ER, urgent care, etc. If you documented that they were non-ambulatory and that they refused to bear weight, without documenting that after whatever it is you did, now they are able to ambulate 3 to 5 steps when they were discharged from the ER. Because you basically told me that you thought you had septic arthritis potentially, and that you did not rule that out. Does that make sense? So as providers, especially in the civilian side, when if you decide to go work in the ER, you will get what's called risk management training. And they will teach you things like that. Don't put this in your chart, because this is what it means to lawyers. Okay, so refusal to bear weight, you never discharge them without documenting that upon discharge now, because you gave them XYZ, or you did XYZ, or you consulted with XYZ, orthopedics, that it was determined that they were not septic in nature, therefore they're going to follow up with their PCM. If you're their PCM, they're going to follow up with you. Okay, good to go? Okay. Because are most children afebrile?
Yes.
Don't look for fever to be the thing. Why is that? Let's back up. When was the illness? A couple weeks ago. Do they still going to have fever?
No.
No. Makes sense? Okay. That's it. That's all that's saying. Okay. But if they have fever, do you think it could be septic? Yes. There could be. Right? In fact, for me, again, I told you how I think, right? All orthopedics things. What do you think? If you tell me fever, I'm thinking infections or otherwise ruled out. Okay, good to go. So, radiographs, right? So what happens? The synovium gets inflamed, it gets enlarged, right? Now, you see this is the contralateral side here, right? This is not the affected side, this is the right side, but the left side is the affected side. So this is actually an ultrasound. So you can get an ultrasound and see that widening there, okay? You guys remember this picture over here where it shows that widening or that inflammation of the synovium itself? Okay, that's what we're talking about when we're talking about that. Okay, so what are we talking about when it comes to widening? You can see on X-ray, the bones appears to be a little displaced compared to where it's sitting on the contralateral side. There's a lot to that. I'm not getting into all those radiographic findings. You just understand that there's a widening of the joint space. Bless you. Because of that inflammation of the synovium. Are we good with that? Okay. Septic arthritis is suspected, urgent ultrasound and aspiration at the same time. Okay? So do you think in a kid that you're suspecting that they have septic arthritis, that you're going to have to put that kid to sleep to put a needle into their hip? 100%. Okay? So this is a big move. It's not just something you do lightly. right? So if you make the diagnosis of transient synovitis and not septic arthritis, that means that you're electing to not do further diagnostic testing. You're still going to keep an eye on them, and we'll talk about that. Okay? MRI, useful to rule out other things. Osteomyelitis, psoas abscess, and what's the last one there? LCP. Okay? Do you think it can be a little tricky with these kids to figure it out?
Yes.
Yeah, it can be a little tricky. That's why usually the ER will call whoever's on call and say, hey, I got a kid, I'm thinking this. You know, they always say kiddo, right? We hate that one. Kiddo. You got a kiddo. Kiddo, what is kiddo? How old is he? Is he skeletally immature? Is he skeletally immature? Like, give me some more. Don't just say kiddo. All right? But we make fun of that. But because then the differential is LCP, correct? Don't be that provider. Don't call it PH and say you got a kiddo, right? What age is a kiddo normally? I don't know. Right? So I have a 4-year-old skeletally immature male with acute onset of a limp. He had a preceding viral illness 2 weeks ago. He's a febrile on physical exam, et cetera, et cetera. So you see how that's orthopedic talk? That's how we talk. Okay? Radiograph show. Unconcerned for. I would like to discuss this with you. Do you mind seeing this patient? Do you mind getting out into your car and driving 45 minutes to come see this kid? All right? 20 minutes. Okay, so hip treatment, non-operative. So we said it was transient, right? So non-infectious. Do you think we treat it conservatively?
Yes.
Yes. These are kids, right? Not kiddos, right? They're young, skeletally immature patients. So do you think we give them NSAIDs? Yes. They're 4 years old. They're young, right? So do you think you give them liquid sometimes?
Yes.
Yeah. So again, those farm, you guys love pharmacology, I get it. But I'm just saying, like, all that stuff comes into play. Activity restriction, bed rest, relative. This is not absolute. Okay? Do you tell them, hey, put them in bed and don't get them out of it. Strap them to the bed if you must. No, we don't do that. Okay? But just relative in this case. Okay? Limp tends to improve within 3 to 14 days. But it can take 4 to 6 weeks for complete resolution. And again, this is transient synovitis to the hip, okay? So you're going to tell the parents that the patient is going to typically improve over the next few days, upward to the next 2 weeks. But then for them to be completely resolved, it could take up to 4 to 6 weeks. Okay? I would know that. Okay? Very commonly tested. Okay? Operative. Sick or substantial discomfort, so meaning you're sick is septic, right? Aspirate and admit for observation. Do we sometimes forego the aspiration and just admit them for observation?
Yes.
Yeah, it's a big move, okay? But if we do aspirate and we're kind of still questioning it, we'll at least admit them because time is tissue. We talked about cartilage destruction, right? All right, do you want cartilage destruction in kids that are growing?
No.
No. Okay. So red flags, substantial pain and limping. What is substantial? They can't bear any weight. Refusal to bear weight. Or when you do force them to do it, they're in a lot of discomfort, screaming, crying, and it's almost like you're torturing them. Does that make sense? So do you think when I go down to the ER and they say they can't bear weight, that I make them stand up and at least shift weight on there?
Yes.
I do. We have our little tricks, okay? You'll learn that stuff next year in phase 2. I won't test you on it this time around. But, you know, you say they can't bear weight, I say challenge accepted. Okay? And I go down there and I make them bear weight. Okay? Because if I don't, I'm the surgery guy, right? I got to make sure that if we need to do the Lord's business, that we do it as soon as necessary, okay? Or as soon as indicated. And that goes with or without systemic signs or symptoms. Okay, so do we necessarily lean on the fact that they're febrile or afebrile? No. Because are they going to be afebrile? Usually, correct? We talked about that. Okay. This is what we discussed today. Okay. In-towing, out-towing. Again, I guys like that pigeon towing, duck-footed, all that. So we don't talk like that. Okay. Understand that when it comes to in-towing, out-towing, that in-towing is the most common, correct? Is it usually physiologic? Yes. So they grow out of it. Okay. So what's the treatment for it? Almost as a rule. Watchful waiting. Okay. When we talk about LCP, we talked about specific age group brackets. Is it osteonecrosis of the femoral head?
Yeah.
Yes, but it's in a specific patient population, correct? Okay, good, good. Osgood-Schlatter disease, that again is pediatrics. If they're adults, they have a history of Osgood-Schlatters, but they actually have tendinitis, correct? Skipping, is that the ice cream cone?
Yes.
Yeah, right, so that's the ice cream falling off its cone, okay? And what kind of patient is this? Someone said it. Don't be afraid to use words. Fat kids with a limp, right? So that, you know, that when I did a review course, when you guys go on the practice, a guy named Joe Gilboy does national review courses. And he would talk exactly like I'm talking now. And I never forgot it. I'm sitting there during the pants, and I'm like, man, I haven't lived this in a while. Like, what was that thing Joe said? And he was like, oh yeah, fat white kids, right? And they with a limp. Okay, and I'm like, okay, yeah. And I'll look at the answer choices, and there it is. Skippy's on there. Okay. So remember that. And I gave you that picture too. Transient synovitis to the hip, is that septic arthritis? How do we treat it? I always get it quiet when I say that. Because everybody's like, we're done. We're gonna stop talking, so you stop listening. So you treat it conservatively. You do things like NSAIDs, relative bed rest, decreased activity. All right, do you strap them to the bed and tell them not to be active? No. Do sometimes those patients, the patient I was talking about was actually a co-worker, one of our CRNA's son. You know, she was probably asking herself, does this guy even know what he's doing? Why is there not a surgeon with him when he's doing this? This is serious stuff, right? And I told her, I said, and I tell you what, he's going to limp on and off for the next 3 days. And then after that, it'll be less frequent. And then about 4 to 6 weeks later, you won't even notice it at all. But every once in a while, you'll be concerned about it because all of a sudden he's limping again. But then it'll go away. I described it just like that, and she was like, she probably thinking herself, she still didn't trust me. But that's what happened, okay? So that's how you're going to educate your patients, and that's the way you should think about it. Because if it's septic, are they going to limp and it's going to go away?
No.
Okay, good. All right, I'll see you guys later. Have a good day.